to tell them you'll get started in just a moment. Just tell them you'll get started in just a minute.
We'll get started in just a minute.
Sure. You can go on and start.
Okay, we're going to go ahead and start. My name is Lauren Williamson. I am a P4 who's with Patrick right now on his NICU rotation. So today we're just going to talk about some general NICU considerations for pharmacists. First, we're going to go over some definitions. So these first definitions are pertaining to the baby's age. So neonates are from birth to 30 days old, and that is regardless of whether they are preterm or postterm babies. Gestational age is the time from the time they are conceived until birth, and that's used to dose certain medications. It's also used in a lot of the notes on the patient chart. Postnatal age is the age in days of life after birth. This is also called corrected gestational age, or CGA. And postmenstrual age is postnatal age is just the days after birth. Postmenstrual age is corrected gestational age. And that's the sum of the gestational age and the postnatal age together. In terms of size, babies can be appropriate, large, or small for their gestational age. Appropriate is anywhere from 10th to 90th percentile. Large is over 90th, and small is less than 10th. And small for gestational age can often be caused by intrauterine growth restriction, or IUGR. In terms of prematurity, that's going to be based on the number of weeks of pregnancy that have been completed. So preterm is before 37 weeks are completed. Moderate to late preterm is 32 to 37. Very preterm is 28 to 32. And extremely preterm is less than 28. They can also be classified by their birth weight. So low birth weight is less than 2,500 grams. Very low birth weight is less than 1,500. And extremely low birth weight is less than 1,000. They're also going to take the mother's obstetric history, and this will be expressed in GPA, or gravida para abortus. If they have had no lost pregnancies, it may be expressed simply as GP. Gravida is the total number of times a woman has been pregnant, and that's going to be regardless of whether they've been carried to term or not. Para is the number of live births she has had, and abortus is the number of pregnancies that have been lost for any reason, whether that's abortion, miscarriage, or any other reason. So, for causes of prematurity, this can be due to spontaneous preterm labor, which has a bunch of different causes. Some common ones are multiple pregnancies, so pregnancies with twins, triplets, or other multiples. If the mother has an infection, she may go into spontaneous preterm labor. The mother's health conditions can also play into this. African American women have a higher rate of preterm labor, as do moms less than 16 years old and greater than 35 years old. The mother's nutrition status can play a role, whether she's obese, whether she's had prenatal care, and then if she has used tobacco or alcohol. They can also be induced into labor or have a C-section due to certain medical reasons. So some common medical reasons that this would happen would be preeclampsia, placental abruption, fetal distress. So just any reason they would need to get the baby out to prevent harm from the baby. If a woman is at high risk for preterm birth, we're going to implement some interventions to try to negate some of those complications. So the first step is to identify any women who may be at risk for preterm birth, and that's going back to the risk factors I mentioned just a second ago. You're also going to screen all the pregnant women for signs and symptoms of infection, because that can lead to preterm labor, and monitor their nutrition status. All pregnant women should be educated about identifying preterm labor so that if it does happen, they can seek treatment. And if a mother goes into preterm labor at or before 32 weeks gestational age, we can give corticosteroids to reduce the risk of the baby developing respiratory distress syndrome, or RDS. And two common steroids that are used are betamethasone and dexamethasone. If the mom has a history of preterm birth, we can also give 17-alpha hydroxyprogesterone caparate, and this helps to maintain the pregnancy until at least 36 weeks. Our treatment goal for preterm labor is to prolong the pregnancy as long as possible, hopefully to term, and we can do that by using tocolytics to stop the labor, and that'll hopefully give us time to at least give antenatal steroids. When the baby's born, we're going to assess them, and a couple of common ways to assess are APGARs and the Ballard scoring system. APGARs are the ones that we use here, and they're the most widespread used. These scores range from 0 to 10, and APGAR stands for appearance, pulse, grimace, activity, and respiration. So each of those 5 factors accounts for 2 points. A score of 0 would be the least responsive, and a score of 2 would be the healthiest response. So you just add those up out of 10. If the baby's APGARs are from 7 to 10, that means they're normal, and if they're below 3, it requires immediate medical attention. And these are performed at 1 minute, 5 minutes, and 10 minutes after birth. The Ballard scoring system is performed at 24 hours of life, and it assesses the neuromuscular and physical maturity of the baby. If we don't know the gestational age of the baby, this can also help give us an estimate of what it should be. All newborns are going to require certain care. These could include warmth, feeding, especially breastfeeding, and a clean environment. For babies that are born at younger gestational ages, they may require additional measures such as infection control, temperature control, feeding support, safe oxygen use, and respiratory care. Breastfeeding should really be initiated within 1 hour after birth, if possible, because this reduces neonatal mortality. It also promotes mother-baby bonding and weight gain for the baby. Kangaroo mother care is a method that is used to also help provide stable warmth and reduce mortality, infections, and hypothermia. And it also encourages frequent and exclusive breastfeeding. And this is direct skin-to-skin contact between the mom and the baby. And this is especially important for babies weighing less than 2 kilograms. All babies, when they are born, are going to get erythromycin eye drop or ophthalmic ointment and intramuscular vitamin K injections. The erythromycin is applied to the baby's eyes to prevent ophthalmia neonatorium, and that can lead to blindness if we don't prophylax for that. The IM vitamin K is to prevent vitamin K deficiency bleeding, and we'll talk a little bit about that later. The next four are really dependent on the baby's status. So hepatitis B vaccine, the first dose is recommended to be given shortly after birth, especially if babies are over 2 kilograms, or to any baby whose mother is hepatitis B surface antigen positive. Caffeine can be given IV or PO, and it's often initiated in the first days of life for premature infants to help with apnea prematurity. Indomethacin can be given IV, and this is for prevention of intraventricular hemorrhage in premature infants. And antibiotics such as ampicillin and gentamicin can be given for the first 48 hours after birth for a sepsis rule out for babies that meet certain criteria, such as maternal history of infection or preterm labor. We're often going to use IVs in these babies because a lot of times we can't give them PO medications. Some lines that are specific to neonates are umbilical cord lines, and these are usually limited to around 1 to 2 weeks due to the risk of infection and just the natural process of the umbilical cord coming off. So the UVC, or umbilical venous catheter, is used to give medicines, parenteral nutrition, anything that we want quickly distributed throughout the body. It also allows us to have more hypertonic solutions. So that's a form of central access. Umbilical artery catheters, or UACs, are often used to monitor blood pressure and prevent us from having to stick the baby so many times to get labs drawn. Another form of central line is a PICC, or peripherally inserted central catheter. And this one isn't specific to neonates, but we will often use them, especially for babies that are going to require more long-term therapy. Peripheral IV lines can be placed in the hands, feet, or scalp. These are limited to just a few days, and we can deliver medications, fluids, or parenteral nutrition through them, but there are some limitations to tonicity. And it's important to note that most NICU babies will have central lines just because they do require so many IV medications and for an extended period of time. Blood volume is another thing to take into consideration with NICU babies, especially premature infants. Premature infants have an average of 80 milliliters per kilogram of blood. So that's a very small amount, especially in these babies that may weigh less than a kilogram. So we want to minimize drawing blood if we can. There are some medications that, if given through an IV and they extravasate, they can cause damage to the baby's skin. So extravasation is when an IV administered medication leaks from inside the vein to the surrounding tissue. So if this happens, we're going to immediately stop the IV push or infusion to prevent any further damage. And then there are pharmacologic and non-pharmacologic management. The non-pharm management would be either warm or cold compresses, and that's going to depend on the drug that was extravasated. And in terms of pharmacologic management, for most medications that extravasate, you can give hyaluronidase injected sub-Q in aliquots around the affected area. But for dopamine, instead of hyaluronidase, you want to give phentolamine, and that's going to also be injected subcutaneously, but this is into the extravasation site. An adjunct to phentolamine is nitroglycerin paste, and that's going to be dosed in millimeters per kilogram. There are a lot of medication safety factors that we should take into account for any patients, but especially patients in the NICU. NICU patients are at higher risk for medication errors compared to other patient populations because the majority of our dosing is weight-based. And weight-based dosing has a very large possibility of error because we often have very, very small doses. And if you move a decimal place, just one place over, you could end up with a 10-fold dosing error. Pharmacists play a vital role in preventing medication errors, so make sure that you are checking and rechecking during the entire process, and that includes ordering, dispensing, delivering. Every step should be double checked. There are many medications that have different dosing regimens based on the indication, so make sure you're checking the correct doses and that the doses are correct for the indication. And another thing to consider is make sure you're using a drug reference that focuses on neonates. Neonatal dosing is not available in every drug reference. So some good ones are Neofax, which we have access to here through Micromedics, the Pediatric and Neonatal Dosage Handbook, and the Teddy Bear book. Also make sure you're double checking all your calculations for accuracy. Again, any tiny error in dosing can be a big difference in these really small patients. And watch for milligrams per kilogram per dose versus milligrams per kilogram per day. That could end up in a big dosing change as well. For instance, if it's supposed to be given every 8 hours versus every day. And as always, watch for milligrams versus micrograms. That can be easy to miss. Another thing is making sure that antibiotics are scheduled appropriately, and then any medications that are dosed and scheduled based on around-the-clock feeding should be taken into account. Medication standardization is also very important. It helps decrease medication errors. So some things that would be ideal would be limiting formulary concentrations. So this gives you fewer options to choose from, less risk of choosing the wrong concentration. Titratable admixtures should also be used, and heparin concentrations for IV admixtures and line flushes are very important. So heparin standardization should be followed, preferably with no deviations, because heparin has been identified as a notorious drug for med errors in neonates. Another thing is predetermined and calculated instructions for admixtures. They should be on hand in the pharmacy for easy access. NICU medication should also be stored separately from the other inventory, so it's good to establish a separate area to store these away from the other inventory, and that includes in the refrigerated section. This decreases the chances of grabbing the wrong medication or the wrong concentration for NICU orders. And because these babies are so small, their oral liquid medications may look a lot like injectable medications because the volume is going to be so small. So it's important to differentiate clearly between oral medications and IV medications, or any injectables for that matter. So a couple things you can do are only using Luer-Lock syringes for injectable medications so that oral medications aren't given IV by mistake. Make sure you clearly label the medications, and then using visibly different syringe caps for orals and injectables. IM injections is another thing that is a little bit different in neonates. So needles in neonates should be no longer than 1 inch, and this is because neonates have decreased muscle mass, and so they have a higher risk of neurovascular injuries if we use a needle that's too large. There's also a limit to the maximum total volume that can be given per injection. In premature infants, that's 0.5 milliliters, and newborns up to 1 year of age is 1 milliliter. Expiration dates should also be checked routinely, and that really goes for any patient population. But again, this is even more important in neonates because neonates have a lower immune response. So any kind of bacterial or microbial growth that occurs in these, the neonate may not be able to fight off that if it is injected. So make sure you are watching for short-dated medications. Dispense all the medications with printed date and time of expiration on the label, and routinely check your medication storage areas and dispose of expired products. In pediatrics and specifically in neonates, there are some drugs that should not be given or should be used with caution. So tetracyclines are one of these that shouldn't be used in kids less than 8 years of age because they can permanently discolor the teeth. Fluoroquinolone should be used with caution in pediatric patients because it has been shown to cause injury to weight-bearing joints in juvenile animal trials. And specifically in neonates, there are some contraindications to several medications. Nitrofurantoin shouldn't be used
Let me
in
turn
the
this thing off.
first
Like we're trying to listen to this thing for a minute.
6 to 8 weeks of life.
I cannot hear you at all. I don't know why. It's like really light and then that thing is like echoing. Okay, gotcha. Okay.
So nitrofurantoin has a risk of hemolytic anemia if it's used too early. So we don't want to use it in less than 6 to 8 week olds.
527. Okay.
Sulfonamides and Rocephin or ceftriaxone also shouldn't be used in patients less than 6 weeks of age because they can displace the bilirubin from protein binding sites, and this can lead to kernicterus, which can cause permanent brain damage, hearing loss, and possibly death. Ceftriaxone also has some other considerations. So it shouldn't be used with any calcium-containing IV fluids in neonates less than 28 days old. So those can include lactated ringers and any parenteral nutrition that contains calcium. So ceftriaxone may be used in neonates, but only if the benefits outweigh the risks, because there are significant risks involved. So we're going to focus on 3 complications of premature babies. We briefly mentioned vitamin K earlier. So vitamin K is given to prevent vitamin K deficiency bleeding, and it's given intramuscularly within the first 6 hours of birth. And this dosing is based on birth weight. So newborns less than a kilogram are going to get half a mg, and newborns at least a kilogram are going to get 1 milligram. There are 3 different types of vitamin K. Vitamin K1 is dietary, so it's going to come from the diet. Vitamin K2 is synthesized by GI bacterial flora. And vitamin K3 is a synthetic water-soluble form that's given as medicine. It's important to note that newborns have almost undetectable vitamin K levels when they're born because vitamin K doesn't cross the placenta, and babies don't have the bacterial flora in their GI tract to be able to synthesize their own, so we have to give it externally. There are 3 different classifications of vitamin K deficiency bleeding. Just briefly mention them, not go into detail. So early is within the first 24 hours of life, classic is within the first week of life, and late is 2 weeks to 3 months of life. And these have different common causes and different common bleeding sites. That's just important to know that they can show up at different times in the neonate. There is also retinopathy of prematurity, and this is a very common complication with premature babies. Preterm birth can delay the development of blood vessels around the retina, especially in small for gestational age babies. So this abnormal growth of vasculature can lead to damage that can result in retinal detachment and blindness. And this is preventable mostly by doing routine eye exams in premature infants to monitor. And when those eye exams are performed, we're going to give cyclopentolate and proparacaine eye drops in advance to help dilate the pupil and to prevent any discomfort. In terms of treatment, you can do laser eye surgery, which can result in some peripheral vision loss. And another option is intravitreal bevacizumab, but that only works in certain regions of the eye. So not all neonates will respond to treatment, and they may require eye surgery to fix a detached retina. And finally, intraventricular hemorrhages are pretty severe complications of prematurity. They're often observed particularly in babies born before 32 weeks gestational age. They're usually seen within the first 72 hours after birth and in infants weighing less than a kilogram. It's classified grades 1 through 4, with grade 1 being the least severe and grade 4 being the most severe. And there are some risk factors listed there. Some ones that we commonly see are choreo, RDS, maternal infection, and there's some others, but y'all can read those. And prophylactic treatment for IVH is pretty controversial. It has significant risks involved, so a lot of people don't like to use it. But if you do give prophylactic treatment, you're going to use indomethacin, which is a non-selective COX inhibitor. And it blocks the synthesis of prostaglandins, and prostaglandins do have some neuroprotective effects. So by inhibiting the synthesis of these prostaglandins, you're going to lose those neuroprotective effects, which is one of the risks of indomethacin use. But it also helps prevent the IVH by inhibiting the alteration in blood-brain barrier permeability. So we're only going to use it in patients who are at high risk for IVH, and some other risks are GI bleeding, hypoglycemia, and thrombocytopenia. And there's an important drug interaction to note with indomethacin, and it shouldn't be used with glucocorticoids if at all possible. It causes an increased incidence of spontaneous intestinal perforations, and this is a drug interaction that's not listed in most drug references, and it doesn't fire a warning in Sterner. So it's one that we need to pay attention to on our own and just keep an eye out for. It can cause some serious issues that we can help negate if we are on the lookout. And this is the book that this chapter comes from. I want to thank y'all so much for listening, and if y'all have any questions, feel free to reach out to Patrick and he can get them to me. Thank you.